He's to talk about retrograde transvenous occlusion, RTO versus tips for gastric varices, the proper choice.
Thank you, Mr. Co-Chairman, and thank you for the invitation, and Ahmed for the opportunity. So I'll be talking very briefly about algorithms treating bleeding gastric varices, including TIPS and BRTO. This is a complicated subject. Is it ready? Yeah. And I'll try to quickly go through this quickly. So with gastric variceal bleeding, it's very different from esophageal variceal bleeding. It's far less common, but it has a very high mortality along with it. The first time bleed from a gastric variceal bleed has about 15% mortality. A second time bleed is about 30% mortality. And cumulatively, a third bleed is about 45 to 50% mortality. Usually, IR kicks in as a secondary prophylaxis, in other words, after a sentinel bleed, whether that IR is a TIPS or BRTO. So you have to be very, very effective in managing gastric varices because your next bleed is usually a 1/3 mortality kind of bleed, okay? And like I said, it's either TIPS, BRTO, or a combination of that, okay? So you just have to basically do what's best you can to try to reduce the actual bleeding. When should BRTO be done versus TIPS versus both of them? And this is kind of the complicated algorithm, and you have to look at TIPS and BRTO as exact opposite of one another. One is creation of a portosystemic shunt, the other is loss of a portosystemic shunt. One, you're decompressing the system, the other one, you're actually compressing or pressurizing the system. So their advantages and disadvantages actually work against one another, okay? They're actually the opposite of one another. So what you need is to tailor it to the best of the patient's presentation and the best of the patient's anatomy, okay? And then in the mix of all this, when do you do partial splenic embolization as well, okay? And this is very complicated, so I can't cover all of it. But generally, this is a very old slide of mine when I first started talking about this about 20 years ago, is that it's not just BRTO versus TIPS. It could be actually TIPS and BRTO or TIPS and BATO. And if you're going to do TIPS and BATO, what do you do first? A TIPS first, followed by BRTO, or BRTO first, followed TIPS, or do them both at the same time? And you basically tailor it to the patient's need, which will go into kind of detail. The hepatic reserve, does the patient is a TIPS candidate or not? Encephalopathy, comorbidities of esophageal variceal bleeding, ascites, hydrothorax, the size of the gastrorenal shunt, what is the predominant feeder, and the compliance and the patency of the portal vein itself. This is a general classification system of gastric varices. You'll see that not all of them have portosystemic shunts. In the type one, you basically have portal shunting. A type B, there's thrombosis, and a type A, there's actually no thrombosis. You have to you don't have to memorize that classification, but actually wrap your head around it. And then comes, when are you actually going to do all this? Do you actually have time for imaging? Do you have time to assess patency? Do you have time to assess there's a shunt? What's the presentation of the patient? What's the hepatic reserve? What's the original hepatic reserve or not at the time of bleeding? And then the splanchnic anatomy, all that pathology. And then you tailor it to all your armamentarium that all these speakers are telling you about, whether it's recanalization, thrombolysis, sclerosis with the BRTO or BATO, and then tipsing or all sorts of other shunts that you can do, okay? So first scenario, it's an unstable bleed, there's bleeding everywhere, endoscopy that can't really identify whether it's esophageal or gastric, the patient is dying, doesn't matter what you're doing a meld or what the meld is right now, it's a heroic TIPS or a salvage TIPS, And so you're going to do a TIPS. You're not going to do a BRTO. You have no time. You don't know the anatomy. You'll just do an emergent TIPS to salvage the patients and to save the patients. Another scenario, patient is stable, okay? Endoscopy identifies as GV bleed. Then you look at history of encephalopathy, MEL score, and then you look at imaging, get imaging since you have time, and then wrap your head, is there thrombosis, no thrombosis, is there a shunt, is it portal-portal shunting or portosystemic shunting? And then under that, there are three categories, three groups of categories. Portal vein circulation is patent, there's portal vein thrombosis, and then there's isolated splenic vein thrombosis, and these are different algorithms for each group. Starting off with a patent circulation. Patient is a TIPS candidate. Also, there's anatomical candidate for conventional BRTO. So you do a BRTO. It's not a TIPS candidate. His MEL is above 18, not a TIPS candidate. There is a shunt. It's straightforward. Not a TIPS candidate, but candidate for BRTO, you do a BRTO. Next case. It's a TIPS candidate, but doesn't have a good gastrorenal shunt. In that case, you do a TIPS and a BATO, an antegrade sclerosis, okay? Next scenario, it's a TIPS candidate and a candidate for BRTO, and this is kind of the controversial part. What are you going to do? Are you going to do the TIPS? Are you going to do a BRTO? And that's kind of controversial. What are you going to start off with? The people that start off with a BRTO say, the consequences of a BRTO is usually ascites, and that's not life-threatening. So I can do the TIPS later. I'll start off with a BRTO. The ones that say put a TIPS in is like, that's the mainstay. We don't want to pressurize the system. We'll actually do a TIPS and then sclerose antegrade. Okay? Those are kind of the two kind of controversial discussions. Okay? So what do? The problem is, there are certain things that will sway you one way or another. This is an example just to show you that BRTO is a lot more effective than TIPS by themselves for gastric variceal control. BRTO rebleed rate is 0 to 3%. After a successful BRTO, the bleed rate is almost 0% at 3 years. I have seen one bleed after a successful BRTO in my lifetime in 20 years, with over 200 BRTOs, and it bled 6.5 years after the original bleed. That's the only bleed that I've seen after a successful BRTO. So it's a lot more effective. When I take you back to the first slide, is that the second bleed is 30% bleed. There's 30% mortality. So you need to be very effective. So you have to do some form of sclerosis. Some form of sclerosis needs to get done. If you're TIPSing and BATOing, or you're BRTOing, or you're TIPSing and BRTOing, you have to sclerose the varices at one point. That is the most important thing, whether you're TIPSing or not, okay? TIPS is not as effective in decompressing gastric varices compared to esophageal varices. There are many theories behind it, but it's usually that the TIPS is far away from the gastric varices for it to actually decompress it. This is a run here showing you a patient that underwent a TIPS, still bleeding from the gastric varices, and now with hepatic encephalopathy. And basically what we did is basically do a BRTO and a BATO and sclerosed and shut down the shunting, improved the encephalopathy, and got rid of all the bleeding. Never bled again for about at least a year, okay? And I can show you case after case after case of just the TIPS with GVs, and the GVs are alive and well and bleeding. If you see the need for TIPS, the incidence of the need for TIPS after BRTO only, it's about 20% over a 3-year period. And about 12% of patients that have a TIPS need a BRTO. Okay? So it sways you more towards BRTO or sclerosing than just TIPSing only. Not only that, the majority of the need for TIPS after BRTO is for ascites. It's not emergent. The majority of BRTO after TIPS as an indication is bleeding, which is emergent. So when you factor in emergent versus elective, when you factor in incidences, it is clearly swaying you towards BRTOing first, or at least definitely sclerosing along with the tips and not just tipsing the patient alone. Okay? So that's the whole key. You need to sclerose the varices, whether you're tipsing or not. Tips and batosclerosis, tips and BRTO, but you need to sclerose the varices whether you're going to put a tips in or not. One of the key things about BRTO or BATO is that in an emergent setting with a Blakemore up, you cannot do a BRTO or a BATO with the Blakemore up. The balloon has to be deflated or disengaged because the balloon compresses the varices. You cannot fill this varices with sclerosants if it's compressed by the balloon. So in an emergent setting with the Blakemore up, you have to disengage the balloon or deflate the balloon to actually do a BRTO or BATO. If you do not want to disengage, then you're going to do a TIPS and bring the patient back for an additional sclerosing. What sways you towards a TIPS when you're doing a sclerosis? And the key thing here is concomitant ascites, extreme gastrorenal shunt. In other words, the shunt is either too large for your inventory or too small where it's not shunting a lot, and a TIPS is more adequate in that situation. Okay? Concomitant esophageal varices. BRTO is going to make esophageal varices worse. So EVs, ascites, very large or very small gastrorenal shunts, that pushes me in the category of tipsing the patient. Okay? Plus sclerosis. Sclerosis is the base. If it's an adequate size shunt that I have inventory for, there are no EVs and ascites, I start off with a BRTO. Okay? So, laterality feeding, that's another complicated subject, but we won't talk about this. For portal vein thrombosis, just to complement the other talks, if you have GV bleeding with portal vein thrombosis or occlusion, if it's acute portal vein thrombosis, you start off by sclerosing the gastric varices first to secure the bleeding, and then you can lyse or thrombectomize. If it's chronic occlusion, you actually do the recanalization at the very beginning. You recanalize the patient because you're not lysing, and then you shut down the shunt at the end. You do not burn your bridge except at the very end after you're able to recanalize the patient. Thank you.
Thank you too much, Professor Wael, for your excellent talk. الحقيقة أنت you encouraged us to start the technique of BRTO. Any question from the audience or chairperson? Actually, I have a lot of questions because you opened a very tricky topic. Number one, what is the technical success in your series of the recanalization of the portal vein thrombosis in chronic?
In chronic portal vein thrombosis?
What is your technical success rate?
In cirrhotics, it will be over 90%.
Over 90%?
Yes. In non-cirrhotics, I would say probably 40 to 50%, to be honest with you.
40 to
50% successful in non-cirrhotics.
In non-cirrhotic, yes.
In cirrhotics, I would say above 90%. Almost, close to 100% in cirrhotics.
Again, you encouraged us to use the BRTO, and I will tell you a case I faced this month, and I need your advice. This is a female, 30 years old, with non-cirrhotic portal vein thrombosis. We tried to open the portal vein, but we failed. And the patient is complaining of chronic encephalopathy.
Of chronic?
Chronic encephalopathy. Chronic.
Okay.
Chronic encephalopathy. And she has very wide gastrorenal shunt. It measures about 25 millimeters. What could you do for such a case?
And she hasn't bled, right? There's no bleeding?
No.
And is it really a gastrorenal shunt or a
Yes.
splenorenal shunt?
Yes, gastrorenal shunt.
So there's gastric varices?
Yes.
I would have to look at the anatomy to see if we can recanalize her or not. And I would also have to look at whether there's enough collaterals or not to shut down the shunt or not. Because sometimes you could do a BRTO and rely on collaterals.
But you know that the shunt is very wide. We have a balloon of 25.
Mm-hmm.
We have large balloon, 25 millimeter.
We have balloons that can actually go to 30 millimeters.
Can we use the IVC filter to occlude the shunt slightly?
I guess you can, and it has been described using filters
Filter.
as a kind of a plug to hold coils and plugs. So
Yes.
there's one case that I know of that's like that.
That's what I did for
Yeah.
this patient, and 1 month later, the patient became very happy and
Okay, good.
concentrating. Thank you very much.
No problem.
Very much for your talk, and
Yeah.
we are coming to my friend Professor Muhammad Shakir. He will speak about the dips and